Hello everybody. Today we are going to discuss the management of the stroke in the simplified form. So first is airway breathing and oxygenation. Airway support and ventilatory assistance provided to the patient who have decreased consciousness and bulbar dysfunction that causes compromise of airway. Supplemental oxygenation should be provided to maintain the saturation level of more than 94%. Oxygenation is not recommended in non-hypoxic patients. Regarding blood pressure, hypovolemia hypotension should be corrected to maintain the appropriate organ perfusion. And patients who have elevated blood pressure and who are eligible for thrombolysis, then carefully lower the blood pressure below 185 by 110 mmHg if a mechanical thrombectomy is planned for the patient and if the patient did not receive thrombolysis. Then also maintain the blood pressure below 185 by 110. Now, how to achieve this blood pressure? So, we can use several agents like labetalol. Labetalol 10 to 20 mg IV over 1 to 2 minutes, and you can repeat one more time. Then we can use nicardipine here, that is 5 mg per hour IV. We can titrate it up to 2.5 mg every hour, 2.5 mg hour every 5 to 15 minutes. Maximum we can give 15 mg per hour. When desirable BP is reached, adjust to maintain the proper BP limits. Then we can use the clevidipine, that is 1 to 2 mg per hour, titrated by doubling dose every 2 to 5 minutes. Maximum that we can give is 21 mg per hour, and we can use other agents like hydralazine and enalprelate. And if BP is not maintained below 185 by 110, then do not administer altiplase. So during the administration of the altiplase, we need to monitor blood pressure every 15 minutes for 2 hours, and then every 30 minutes for next 6 hours, every hour for next 16 hours. And if the still BP is high and if it is not controlled, then we can escalate our measures, like we can start labetalol 10 mg IV followed by continuous infusion of 2 to 8 mg per minute, then nicardipine 5 mg per hour, which is titrated by 2.5 mg per hour every 5 to 15 minutes. Maximum that we can give is 15 mg per hour. Then we can also use the clevidipine, that is 1 to 2 mg per hour, and titrate by doubling the dose every 2 to 5 minutes until the desired BP is reached. Maximum that we can give is 21 mg per hour. If BP is not controlled, or if still diastolic blood pressure is high, if it is more than 140 mg, then we can consider IV sodium nitroprusside. Regarding management of the temperature, we should avoid hyperthermia. Antipyretic medication should be administered to reduce the temperature. Then, regarding the blood glucose level, avoid hypoglycemia that in patient with the ischemic stroke, and also patient should not be hyperglycemic in first 24 hours, and we should try to maintain the blood pressure between the range of 140 to 180. Now, regarding revascularization, we have the two options for revascularization. One is IV thrombolysis, and the second option is endovascular treatment. For IV thrombolysis, we can use three agents, that is altiplase, tenecteplase, and retiplase. So altiplase is the only thrombolytic agent which is approved by FDA for used in acute ischemic stroke. So what is altiplase? Altiplase is the recombinant tissue type plasminogen activator, and it is a glycoprotein which is composed of 527 amino acid. So endogenous tissue plasminogen activator and the recombinant altiplase, it will break down the fibrin in thrombi by cleaving fibrin-bound plasminogen to plasmin, which is a proteolytic enzyme involved in proteolysis. So this altiplase has very short half-life, that is 4 to 5 minutes. Hence, altiplase should be administered in the bolus and infusion form. So dose of the total IV altiplase is 0.9 mg per kg. Of that, 10% should be given in the form of bolus, and the remaining dose should be administered over 1 hour. So benefit of therapy is time dependent and should be administered as soon as possible. Now we'll see what are the class 1, class 2, and class 3 indication for administration of recombinant tissue plasminogen activator. So class 1 indications are a patient who presented within the 3 hours of ischemic stroke, and age should be more than 18 years. It is equally recommended for more than 80 years of patient. For severe IV alteplase, it is in for severe stroke. IV alteplase is indicated within 3 hours from onset of ischemic stroke. And if the patient is presented to us with the mild but disabling stroke, then IV alteplase is recommended for patient who can be treated within 3 hours of ischemic stroke. Now, these indications are different for patient who presented to us within 3 to 4.5 hours of period. Like for a patient who are less than 80 years of age, uh, if a patient is coming to us in window period of 3 to 4.5 hours, then the age of the patient should be less than 80 years or equal to 80 years. Patient should not have diabetes mellitus or prior history of stroke. Then NIHSS score is less than 25. He is not taking any oral anticoagulation, and he should not have any imaging evidence of ischemic injury involving more than one third of MCA territory. So IV alteplase is recommended for patient taking antiplatelet monotherapy and dual antiplatelet before stroke on the basis of evidence that benefit of alteplase outweigh the small increase in the rise of ICH. In case of end-stage renal disease on hemodialysis and a normal hepatitis, IV alteplase is recommended. And those with elevated hepatitis may have elevated rise for hemorrhagic transfusion. Now, relative indication, that is class 2 indication. If a patient presented to us in 3 to 4.5 hours, then the age of the patient is more than 80 years, then IV alteplase is safe and can be effective. Patient with prior stroke and diabetes mellitus, patient with the very severe stroke, mild disabling stroke, then wake up stroke of unknown time of onset, or any unclear time of onset more than 4.5 hour, and who have diffusion weighted MRI lesions smaller than one third of MCA territory and no visible signal change on flare. Acute stroke with the pre-existing disability may be reasonable, but decision should be taken in the account of relevant factors like quality of social life, social support, place of residence, need for caregiver, and pre-existing. If patient has a pre-existing dementia, then also we can consider giving IVL treatments. In case of moderate to severe stroke, demonstrated early improvement, but remain moderately impaired and potentially disabled. Then seizure at onset of stroke, if impairment if there's focal deficit is secondary to stroke, if initial glucose levels are less than 50 and more than 140, if there is history of any IV warfarin use, and if INR is less than 1.5, prothrombin time is less than 1.5 second, if lumbar puncture is lumbar puncture was there in preceding 7 days. Arterial puncture of non-compressible blood vessel in 7 days preceding stroke onset. Then major trauma not involving head. Major surgery in preceding 14 days. Alteplase administration within 21 days of GI bleed. And women who are menstruating and do not have history of menorrhagia. Known or suspected to be associated with extracranial cervical artery dissection. It's safe within 4.5 hours. Small and moderate size, unruptured, unsecured intracranial aneurysm, unruptured and unthreatened intracranial vascular malformation, small number of cortical microbleeding. That is, if it is in the range of 1 to 10, then administration of alteplase is reasonable. If there is a high burden of cortical microbleeding, that is, if it is more than 10, then the treatment of alteplase might lead to the intracranial hemorrhage. Then efficacy of IV glycoprotein, that is 2B3 inhibitor, that is tirofiban and the eptifibatide, co-administration with IV alteplase is not well established. Patient with extra and intracranial neoplasm and concurrent acute ischemic stroke and acute MI treatment with IV alteplase at dose of appropriate for cerebral ischemia followed by PCI stenting is indicated. For patient with acute ischemic stroke and acute MI in past 3 months, treating the acute ischemic stroke with IV alteplase is reasonable if the patient is if a recent MI is STEMI. It is reasonable in case of STEMI also if it is involving right and inferior myocardium, and in case of STEMI involving left anterior wall. Major acute ischemic stroke likely to produce disability and acute pericarditis. Treatment with IV alteplase is reasonable. Moderate acute ischemic stroke likely to produce mild disability and acute pericarditis treatment. Then treatment with the IVLT is of uncertain benefit. Then patient with the known left atrial and ventricular thrombus, patient with cardiac myxoma, patient with the papillary fibroelastoma, patient with complications of cardiac and cerebral angiographic procedures, and patient with current malignancy. It may be considered in pregnancy, and it is safe and safety and efficacy in early postpartum period, that is less than 40 days, have not well established. Then, in case of history of diabetic hemorrhagic retinopathy, again class 2 recommendation, if the known sickle cell disease, hyperdense MCA sign, then illicit drug use associated with acute ischemic stroke, we can give in the case of stroke mimic because of the symptomatic hemorrhage is quite low. Now class 3 recommendation for administering IVLT is mild non-disabling stroke. If someone is presented to us with NIHSS score of 0 to 5, then is not recommended for patient, even if who could be treated within 3 hours or 3.5 hours. Then CT brain imaging exhibiting extensive area of clear hypoattenuation, CT brain revealing intracranial hemorrhage, then prior ischemic stroke within 3 months, recent head trauma within 3 months, post-traumatic infarction, history of intracranial and intraspinal injury within the past 3 months. History of intracranial hemorrhage, history of SAH, then any history of GI malignancy and bleed in last 21 days, patient with acute ischemic stroke and symptom with infective endocarditis, aortic arch dissection, intraaxial and intracranial neoplasia. Then regarding administration of this IV altiplase, we should infuse in the dose of 0.9 mg per kg. That is maximum dose that we can give is 90 mg over 60 minutes. Out of that 10% dose should be administered as a bolus within the 1 minute. Then admit the patient in the intensive care unit and the stroke unit for monitoring. If patient develops severe headache, hypertension, nausea, vomiting, and at worsening neurological examination, then discontinue the infusion and obtain the emergency head CT. Measure the blood pressure and perform the neurological assessment every 15 minutes during and after IV altiplase administration for 2 hours. Then every 30 minutes for next 6 hours, and then hourly monitoring should be there for next 24 hours. Then increase the frequency of blood pressure measurement if the systolic blood pressure is more than 180 and if diastolic blood pressure is more than 105. Administer antihypertensive medication to maintain the blood pressure below this level. Then delay the placement of nasogastric tube, indwelling bladder catheter, intra-arterial pressure catheter if patient can be safely managed without them. Then we should obtain the follow-up CT and MRI scan at 24 hours after IVLT place before starting anticoagulant and antiplatelet agent. Then management, how to manage the symptomatic bleeding which occur within the 24 hours after administration of IVLT. So first is we should stop the infusion of IV altiplase infusion. Immediately send the investigations like CBC, PT-INR, APTT, fibrinogen level, and the cross match. Then we should take non-contrast head CT. Then we should administer cryoprecipitate, which include the factor 8, 10 unit infused over 10 to 30 minutes. Then administered additional dose of fibrinogen if the levels are less than 150. Tranexamic acid 1 gram IV over 10 minutes or aminocaprionic acid 4 to 5 gram over 1 hour, followed by 1 gram IV until bleeding is controlled. Then immediately we should take hematology, neurosurgery consultation. Supportive therapy should be offered in including BP management, ICP control, cerebral perfusion pressure control, MAP, temperature, and blood glucose control. So in case if the patient develops angioedema with IV altiplase infusion, then how to manage? So immediately go for endotracheal intubation. Then Endotracheal intubation, this may not be necessary if edema is limited to the anterior tongues and lips. If edema involving larynx, palate, floor of mouth, oropharynx with rapid progression, then patient is at high risk for requiring intubation. Awake fiber optic intubation is optimal. Nasal tracheal intubation may be required, but it carries the risk of epistaxis after IV altitudes. Cricothyrotomy may be rarely needed and also problematic after IV altiplase. Discontinue IV altiplase infusion and hold AC inhibitor. Administered IV methylprednisolone at the dose of 125 mg. IV diphenhydramine 50 mg. Administered ranitidine 50 mg IV and famotidine 20 mg IV. If there is further increase in angioedema, then treat it with the epinephrine, that is 0.3 ml subcute or by nebulizer 0.5. Then other fibrinolytics agent, it may be reasonable to choose tenecteplase in the dose of 0.25 mg per kg, maximum for 25 mg over altiplase in patient without contraindication for IV fibrinolysis and who are eligible to undergo mechanical thrombectomy. Tenecteplase should be given in the dose of 0.4 mg per kg IV bolus that have not been proven to be superior or non-inferior to altiplase, but might be considered to be alternative to altiplase with minor neurological impairment and no major intracranial occlusion. The administration of fibrinolytic agent other than altiplase and tenecteplase is not recommended. Then regarding mechanical thrombectomy, patient eligible for IV altiplase should receive IV altiplase even if mechanical thrombectomy is being considered. If in patient under the consideration for mechanical thrombectomy, observation of IV altiplase to assess for clinical response should not be performed. Now, the patient should receive mechanical thrombectomy or with stent retriever if they meet following criteria. If pre-stroke MRSA score of 0 to 1, positive occlusion of internal carotid artery and MCA segment M1, if age of the patient is more than or equal to 18 years, if NIHSS score of more than or equal to 6, if aspect score is more than or equal to 6, then treatment can be initiated, and if treatment can be initiated within the 6 hours of symptoms. Now, direct aspiration thrombectomy as first pass mechanical thrombectomy is recommended, and it is a non-inferior to stent retriever if patient meets all of the following criteria. And then pre-stroke MRSA score of 0 to 1. If there is a occlusion of internal carotid artery or M1 segment, if age is more than or equal to 18 years, if NIHSS score is more than or equal to 6, aspect score more than or equal to 6, and if you are starting treatment within the 6 hours. Although benefits are uncertain, the use of mechanical thrombectomy with stent retriever may be reasonable for a patient with acute ischemic stroke in whom treatment can be initiated within 6 hours of onset and who have occlusion of MC segment M2 and MCA segment M3 portion of middle cerebral artery and have pre-stroke MRSA score of more than 1, aspect score less than 6 and NIHSS score less than 6, occlusion of internal carotid artery and proximal middle cerebral artery, and who have occlusion of anterior cerebral artery, vertebral artery, basilar artery, or posterior cerebral arteries. Then how to treat with the stroke who presented to us within 6 to 24 hours from onset. In selected patient with acute ischemic stroke within 6 to 16 hours from last known normal and who have left a large vessel occlusion in anterior circulation and who met other dawn and diffuse 3 eligibility criteria, then mechanical thrombectomy is recommended. If in selected patient who presented to us with acute ischemic stroke within 16 to 24 hours of last known normal and who have large vessel occlusion in anterior circulation and who meet the down eligibility criteria, then mechanical thrombectomy is reasonable. Now, regarding blood pressure management in patients who undergo mechanical thrombectomy, it is reasonable to maintain the blood pressure below 180 by 105 mmHg during and for 24 hours after the procedure. And in patients who undergo mechanical thrombectomy with successful reperfusion, it might be reasonable to maintain the blood pressure at this level. Now, other endovascular therapy, mechanical thrombectomy with stent retriever is recommended over intraarterial fibrinolysis as first line therapy. Then, intraarterial fibrinolysis is initiated within 6 hours of stroke onset in carefully selected patients who have contraindication to use a use of IV altiplase, but consequences of this are unknown. Regarding administration of antiplatelet therapy, administration of aspirin is recommended in patients with acute ischemic stroke within 24 to 48 hours after onset. For those treated with IV altiplase, aspirin administration is generally delayed until 24 hours, but might be considered in the presence of concomitant condition for which such a treatment is given in the absence of IV altiplase, and known to provide benefit, or withholding such a treatment is known to cause substantial risk. In patient presenting with the minor non-cardioembolic ischemic stroke, that is NIHSS score less than or equal to 3, who do not receive IV altiplase, then we should treat this patient with dual antiplatelet started within 24 hours after symptom onset and continue for 21 days, and is effective in reducing recurrent ischemic stroke for a period up to 90 days from symptom onset. Then regarding anticoagulation, usefulness of urgent anticoagulation in patient with severe stenosis of internal carotid artery ipsilateral to ischemic stroke is not well established. Now, regarding emergency carotid endarterectomy, carotid angioplasty, and stenting without intraarterial clot, the usefulness of emergent and urgent carotid endarterectomy, carotid angioplasty, and stenting when clinical indicators of brain imaging suggest small infarct core with large territory at rest, compromised by inadequate flow from critical carotid stenosis or occlusion, or in the case of acute neurological deficit after carotid endarterectomy, in which acute thrombosis of surgical site is suspected, is not well established. In patient with unstable neurological status, for example, stroke in evaluation, the efficacy of emergency or urgent carotid endarterectomy and carotid angioplasty and stenting is not well established. Thank you.